Welcome to all of you. I am Dr. Shivika Sethi and I'm here to discuss the microbiology MCQs that were asked in the recently held NEET-24 exam. Let me start with the assessment of the MCQs. Most of the MCQs that were asked were clinical vignette based. A couple of them had images attached to them which were contributing to our answer. The questions were of moderate difficulty level. But if you had done your microbiology notes or the videos well, you would have got all of the questions absolutely correct. And of course, contributing to it is the fact that you should be remaining calm and composed during your exam. The questions were absolutely new ones, meaning there were no PYQs in microbiology. About 50% of the questions were from previously asked topics, meaning from the last 5 years or so, but the rest of them were absolutely new topics. So what does that mean? That if you just do the previous year questions, you cannot get all the questions correct in microbiology. Okay, so be careful that just don't think that you can get away by doing the previously asked questions or the previously asked topics. So this was quite it was quite a new situation. There were hardly any previously asked topics, or rather previously asked questions. Okay, now disclaimer right before I discuss the questions, that these are questions which have been compiled by us on the basis of the recall by the questions. So there might be some discrepancies in the in the options or in the question itself. So pardon us for that. And it would be great if you could contribute to any discrepancy that you came across in the questions in the comments of this video. That would really help the other students who are, who are watching these videos later. Okay, let's get going with the questions. Since there were 2 sessions of the exam, I will be taking up session 1 MCQs in the first part and session 2 MCQs in the latter half. Comparing the 2 sessions would be very, very difficult because there were no topics. There was just one topic that was repeated in, amongst the 2 sessions. So the questions were absolutely different from session 1 and session 2. And I can't say which one was tougher, which one was, because it depends upon for me, they were all a breeze. But for you people, depending upon how much you have studied, you could have just, session 1 is not comparable with the session 2 because either of them were equally difficult. Let's get started with the MCQs. A young man who often eats outside on account of his occupation presents to the OPD with complaints of fever that has been increasing every day since the last 4 days. He also has headache, pain, abdomen, and diarrhea. On examination, he has pink macules on the trunk and bradycardia. So what is this telling us? The patient has fever along with bradycardia. What sign is this? This is called as the Fagett sign, and we have pink macules on the patient's trunk. Obviously, we're going to think of enteric fever. Okay, so these are the rose spots. Which of the following investigation would best help in the diagnosis of this disease? Vidal, urine culture, blood culture, and stool culture. This is very straightforward. It's the first week of symptoms. Our answer is definitely blood culture because blood is positive in more than 90% of cases in the first week of disease. Okay. Antibodies which are detected by the Vidal test, these will appear in the second week of the disease. Urine culture later around the 4th week, and stool culture around the 3rd week. Okay. So our answer, pretty easy, is blood culture. Let's move on to our next question. A patient with history of consumption of oysters comes with complaints of nausea, vomiting, and crampy abdominal pain. The stool culture isolate shows hemolysis in high salt human blood agar. What is this special thing? When you think of salt being added to a medium, we are thinking of Vibrios, which are alkali files, and this is human blood agar. So what is this? This is Vagatsoma agar, which is human blood agar with added salt, and it is showing hemolysis. What is this phenomenon called as Kanagawa phenomenon, and which is demonstrated by Vibrio parahaemolyticus. We know Vibrio parahaemolyticus is associated with ingestion of seafood, okay, and it presents with an invasive enteritis, right? So this is Kanagawa phenomenon. This is a pathogenic strain of Vibrio parahaemolyticus. Our answer is very straightforward, option A, okay. Please remember that 3 organisms associated with intake of seafood. One we've just talked about, Vibrio parahaemolyticus, presents with invasive enteritis. Another one is Vibrio vulnificus, and there the patient will present following the intake of seafood with septicemia, and a virus which is associated with seafood is norovirus. Okay, remember these 3 organisms with seafood intake association. Moving on to our next question, a patient on long-term IV antibiotics has a central venous line. He develops high fever. Blood cultures grow staph epidermidis. That's pretty simple. It's the most common cause of bacteremia in patients who are IV catheterized. Despite starting antibiotics, according to the sensitivity profile of the isolate, fever does not resolve. I'm not sure about the wordings of this question. Please just pardon us for that, because basically we need to know what was the question actually asking us. Which of the following statement is correct with regards to the role of biofilm in this patient? Okay. Biofilm increases the susceptibility to antibiotics. That is absolutely incorrect. It reduces the susceptibility to antibiotics. Why? Because it is enclosing the bacterial colonies. So it is preventing the entry of antibiotics, right? So obviously it will reduce the susceptibility to antibiotics. It acts as a mechanical barrier. Biofilms act as mechanical barriers to the entry of antibiotics. Biofilm helps in adhesion. Yes, that's absolutely correct. But here, since the patient is not responding to the antibiotic according to the sensitivity profile, that adhesion has no role here. It is the prevention of entry of antibiotics. Option C, biofilm reduces the resistance to antibiotics reduces the susceptibility to antibiotics by offering resistance to entry. So catheter is to be removed. Absolutely correct. Yes, we need to remove this patient's catheter because staph epidermidis has formed biofilm around its colonies, and that's preventing the entry of antibiotics. Option D, biofilm can be washed off from the catheters, hence catheter need not be removed. That's absolutely incorrect. So even this option is option B. Here it is not correct. Yes, biofilms do help in addition, but here it's not relevant in the no response to antibiotics in this patient. So please remember that certain bacteria produce what is called as a polysaccharide layer around their cell wall, which is known as slime. And when slime collects, it leads to the formation of biofilms, right? So this is the slime that has formed, and if it's a bacterial colony, a biofilm is going to form. Now, remember, one role of biofilm in pathogenicity of bacterium is adhesion. Second role is it prevents or protects from bacteriophages. And thirdly, it reduces the entry of antibiotics. That was what was relevant out here. It is forming a mechanical barrier. And if you've read my notes, I've talked about staph epidermidis that was mentioned in this question, Streptococcus mutans, and Pseudomonas aeruginosa. These are 3 bacteria which are notorious for forming biofilms. They are notorious for forming biofilms. Moving on to our next question. A child is brought with complaints of abdominal pain and perianal itching. Our biggest hint is right there in the first sentence. The mother said she noticed white thread-like structures in the child's night clothes. She collected the worm and brought it to the clinician. A perianal swab was collected. Microscopy of the swab and the worm are shown in the images. What is the likely organism? We already knew the answer to this question by this perianal itching or pruritus ani. We don't even need to look at what is shown in the images. That's the plano-convex egg with the folded larva of Enterobius vermicularis. I don't know why. I'm not interested in what the worm look like, but because I already know the answer is pinworm, threadworm, or seatworm, that is Enterobius vermicularis. Because why does the patient have perianal itching here? Because in the night, the female worm present in the large intestine migrates down to lay the eggs on the perineal skin, right? That's why the child is presenting with pruritus ani. Okay, this is the egg, of course. This is the egg, of course. Please remember that was mentioned. Please remember the stool is not productive in enterobius infection because the eggs have been laid on the perianal skin. Okay, so that's why we do what is known as the NIH swab. Okay, so I'll just show you the eggs of Ankylostoma duodenale because these are important. They're asked as image-based question and they have been asked. This is the egg of the hookworms, Necator and Ankylostoma, which are found in the stool. This is the segmented ovum with blastomers. This is the egg of Hymenolapis nana. H. nana. It's got a hexacanth oncosphere and it's got polar filaments with yolk granules out surrounding this hexacanth oncosphere. A thalassemia patient has received multiple blood transfusions. Aplastic crisis can occur in this patient due to infection from which of the following? So this is a patient with chronic hemolytic anemia. Generally, sickle cell anemia or thalassemia as mentioned in the question. Of course, what is the virus which can cause aplastic crisis? Because it infects erythrocyte precursors, that is Parvovirus B19. Parvo has been a favorite in the last few years. This is a repeatedly asked question. Please remember to study Parvovirus before every exam. Okay, so aplastic crisis in chronic hemolytic anemia patients. A thermally dimorphic fungus, so we have been asked about dimorphic fungi, shows arthrospores in its mold state. It causes desert rheumatism. What is the likely or identity of this fungus? Of course, our answer is Coccidioides immitis. Desert rheumatism is the other name for coccidioidomycosis. It's also called as valley fever. It's also called as San Joaquin Valley disease, or it's also called as California disease. Okay, right, and I'll just show you the typical barrel-shaped arthrospores of Coccidioides in the next slide. Before that, please remember, this is a very easy way to remember the mold form of dimorphic fungi is seen at room temperature. So, room temperature 25 to 28 degrees Celsius is the mold form. M, it's ending in M, so the mold form is seen here. Body, that is 37 to 37 degrees Celsius, the yeast form is seen. Okay. We know there are 6 dimorphic fungi for us to remember: Histoplasma capsulatum, Blastomyces dermatitidis, Coccidioides immitis, Paracoccidioides brasiliensis, Sporothrix schenki, and Teleromyces marneffi, right? So, let's see the images. These are the barrel-shaped arthrospores that were mentioned. So, this can be asked as an image-based question. Barrel-shaped arthrospores of Coccidioides, and this is the yeast form of Coccidioides seen at body temperature, that is spherules filled with endospores. A patient receiving chemotherapy develops pneumonia with skin lesions. So, this is an immunodeficient patient developing pneumonia with skin lesions. Microscopy of the biopsy of the skin lesions shows broad-based budding yeast. Okay, this is so simple. Of course, we know broad-based budding yeasts are seen in Blastomyces dermatitidis. So easy. Culture of the biopsy yields white colonies, LPCB mount of which shows hyphae with conidiospores. So don't get psyched by the huge amount of content written in the question. The one clinching word only can tell you what is your answer. Okay, so here our clinching words were broad-based budding blastomyces. Okay, this is very simple. Let me show you the image. That's our figure of 8 appearance. Figure of 8 appearance or hourglass appearance or broad-based budding of blastomyces, and these are the hyaline septate hyphae with conidiospores of blastomyces. Okay. So this is also a dimorphic fungus, as I just told you in the previous question. A 45-year-old farmer comes with complaints of high-grade fever. So here we have a farmer with fever, chills, retroorbital pain, and conjunctival suffusion. This is our biggest hint, conjunctival suffusion with fever in a farmer. On examination, he has severe calf tenderness. Lab investigations show hypokalemia, neutropenia. What is the likely diagnosis? Leptospirosis, dengue, chikungunya, and malaria. Okay. The word farmer is telling us it's a disease associated most likely. When an occupation is mentioned, think of specific diseases associated with those farmers. Farmers wade through water contaminated with animal urine, especially rodent urine, and they develop leptospirosis. Some of the students got confused with dengue because they read retroorbital pain. But there is something glaring in your face, conjunctival congestion or conjunctival suffusion with calf tenderness is typically seen as in leptospirosis, right? So this question is a repeat again and again in the last 5 to 6 years. It has been asked. Leptospirosis is a favorite, just like parvovirus is a favorite. Similarly, leptospirosis is a favorite. So this is what is conjunctival suffusion. A man is brought to the emergency with fever, headache, and vomiting for the last 1 day. On examination, he has photophobia, neck rigidity, and petechial skin rashes. So meningitis associated with petechial, purpuric, or ecchymotic rashes would be meningococcal meningitis. Brudzinski signs and Koenig signs are positive. Microscopy shows gram-negative diplococci. We know the answer is Neisseria meningitis. This is also a repeatedly asked question regarding meningococcal meningitis. It can also be asked as an image-based question. CSF can be shown. Gram staining is like this. So you can see the gram-negative diplococci out here. Okay. So pink colored diplococci. A farmer from Kerala presents with fever. So this geographical history, fever, respiratory distress, and neurological deficits. The reservoir of the causative organism is shown below. What is the likely associated organism? This is definitely, what is this? You can see the fruit out here, and this is the fruit bat, which is the reservoir for both Nipah virus as well as Ebola virus. But because of this geographic location, we can definitely say this is Nipah virus because Kerala has repeatedly reported outbreaks of Nipah virus encephalitis, right? The reservoir is fruit bat. Okay. The others can be easy. For Zika, the reservoir are primates. For malaria, there is no animal reservoir except for the Plasmodium knowlesi, for which the reservoirs are chimpanzees. Right? Ebola is only reported from Africa, not yet reported from India, and thank God for that. And plus, it will not present with neurological deficits. It will present with hemorrhagic manifestations. It's a hemorrhagic fever reported in Africa. This is how what is the transmission cycle of Nipah virus. The reservoirs are fruit bats. Humans can get the infection by consuming fruits which have been contaminated by infected bats, or they also infect pigs. So while handling infected pigs, humans can get infection. Plus there is human to human transmission of Nipah virus. Moving on to our next question. A young sexually active female presented with frequency of urination and pain during micturition. A midstream urine sample was collected. Urine analysis and cultures showed novobiocin-resistant coagulase-negative staphylococci with a count of 10 raised to power 4 colony-forming units per ml. Okay, so we have a symptomatic UTI. And what is the organism? Can you guess what it is? Novobiocin-resistant cons. This is Staph saprophyticus. And the counts in which it is present is 10 raised to power 4 colony-forming units per ml. What is true about this condition? Diagnose as UTI and treat. This is our correct answer. Let's read the other options. The test must be repeated with a fresh specimen. Does not need repetition. Why? Because these counts are significant counts. It is not asymptomatic bacteria. The patient is presenting with symptoms. It's a normal skin commensal which has grown on culture that does not need to be treated. Staph saprophyticus is one of the common causes of UTI in young females who have recently become sexually active. Yes, it may be a normal skin commensal, but yes, this needs to be treated because it is present in significant counts. Okay. Please remember that there is a criteria for diagnosing UTI. So some of you might be wondering, what is this 10 raised to power 4? This should be 10 raised to power 5. But that criteria is for asymptomatic bacteriuria, more than or equal to 10 raised to power 5 colony forming units per ml in a clean catch midstream urine sample is significant for asymptomatic cases. However, for symptomatic males, the counts are 10 raised to power 3 colony forming units per ml in a clean catch midstream urine sample, and for symptomatic bacteriuria in females, it is 10 raised to power 2 colony forming units per ml in a clean catch midstream urine sample. And this female had 10 raised to power 4. So this is definitely significant. The patient has UTI. She needs to be treated. A 30-year-old male presents with cough and dyspnea for the last few days. During his workup, he is found to have a deficiency of complement proteins that are involved in the formation of the membrane attack complex. What is the most likely infection? I hope you remember what are the components of the membrane attack complex C5 to C9. Deficiency. Terminal complement proteins are involved in the formation of the membrane attack complex, and we know the most important association in such individuals is Neisseria. There are 1,000 times increased risk of Neisseria infections in patients who have deficiency in either of these complement proteins. A 6-month-old child presents with acute watery diarrhea. Electron microscopy of the stool showed spoke-weak-like appearance as is shown in this image. So this is mentioned out here, spoke-weak-like. So this is definitely rotavirus. Rotaviruses have a wheel-like appearance. Okay, wheels rotate. That's the reason they are named as rotavirus. What is the likely cause of diarrhea? Astro-rotavirus, that's our answer, adeno and Norwalk. All of these viruses can cause diarrhea, but because this is mentioned spoke-weak-like and the child is 6 months old, most common cause of diarrhea in such individuals, in such children is rotavirus. Okay. So this is the electron microscopic image of rotavirus. A young promiscuous male presents with patchy loss of hair as shown in the image and moist grey pedunculated lesions in the perianal regions for the last few weeks. On examination, painless macules on the back are noticed. What is the most likely etiology of the patients? Now, this question also confused many students. Some of them marked malassezia. What does malassezia cause? It just presents as these macules on the back, pityriasis versicolor. But there are 2 more symptoms mentioned out here. The patchy loss of hair, alopecia, along with these moist pedunculated lesions in the perianal regions. What are these? Condyloma lata. So this triad, alopecia with condyloma with bacular rash, this is definitely secondary stage of syphilis. The answer to our question is Treponema pallidum. Okay, now let us move on to the questions that were asked in session 2. So we had 3 questions from gonococcal urethritis. Let's start with the first one. A middle-aged man with history of unprotected sexual intercourse complains of pain during micturition and itching. On examination, gram-negative intracellular cocci are seen. What is the most likely organism? This is so simple. Gonococcal urethritis, we can see the gram-negative intracellular cocci inside the macrophages. Okay. Next question that was on gonococcal urethritis was regarding the selective medium. A young man presents with itching, painful micturition. Microscopy showed gram-negative intracellular kidney-shaped organisms. Which of the following culture medium is used to isolate the organism? Pretty simple. Thayer, Martin, agar, which contains 3 antibiotics, vancomycin, colistin and nystatin to make it selective for Neisseria. Okay, that's our answer. Blood agar is not a selective medium. All bacteria would grow. McConkey is a selective medium for gram-negative organisms, but only those which do not have any special nutritional requirements. So Neisseria would not grow on McConkey because it is requiring an enriched medium. Muller-Hinton agar is classically used for antibiotic sensitivity testing. So our answer is option A. A middle-aged man presented to the OPD with dysuria, purulent urethral discharge. This has been asked as an image-based question 2 years back. Since the last 3 days, so there was typical in that question, it was purulent urethral discharge in the image. Gram stain of the discharge is shown in the figure. He admits to having unprotected sexual intercourse 1 week ago. What is the most appropriate treatment? So they want to know everything about gonococcal urethritis. How are you going to treat this patient? By either giving injection intramuscular, ceftriaxone 500 milligram intramuscularly, or you will give tablet cefixime 400 milligrams stat. Okay, that's how we treat gonococcal urethritis. A patient diagnosed with HIV presented with complaints of recurrent diarrhea. Stool microscopy shows only motile larvae and no ova. So we have an HIV patient and presented with diarrhea. No ova are seen, but we are seeing something motile mentioned as larvae. Which of the following is the most probable causative organism? This is definitely Strongyloides, which is famous for causing opportunistic infections in immunodeficient like HIV transplant recipients. And why are we not seeing eggs in the stool? Why are we seeing larvae? Because Strongyloides is ovoviviparous. What does it mean? That the female lays the eggs in the GI tract, but these will immediately hatch. Rhabdidiform larvae are what we are seeing in the stool of the patient. Rhabdidiform larvae. That's how we. Let me show you the image. This has been asked as a GIF-based question also, where we immunodeficient patient, and this is seen on stool microscopy. Don't get psyched. Okay, these are the larvae of Strongyloides, right? And in Enterobius, we do not see eggs or larvae. In the stool, we see on the perianal swab. Ascaris and ankylostoma, we are going to see the eggs, not the larvae, right? So remember, Strongyloides is again a very, very important topic for our exams, just like Parvovirus, Leptospirosis, Histoplasma is very important, and Neisseria is very important. Similarly, Strongyloides is very, very important. A couple of important things. Always remember the females are parthenogenic, meaning they do not need fertilization by the males to lay the eggs, and the fact that they are ovoviviparous, they cause opportunistic infections in immunodeficient, and they are known to cause auto-infection in immunodeficient, which can lead to disseminated strongyloidesis along with gram-negative bacteremia. Okay, let's move on to our next question. A middle-aged man presented with many febrile episodes for the last couple of years. He also has complaints of itching, discoloration and swelling of lower limb. On examination, the patient has unilateral left lower limb edema. On blood examination, we are seeing sheathed larvae of the size 200 microns and these are devoid of any nuclei in the tail tips. So this is lymphatic filariasis, and we know there are two causative organisms of lymphatic filariasis in our country, Wuchereria and Brugia. Which one of them is associated with absence of nuclei in the tail tips? It is Wuchereria. Okay, this is again very important for our exam. In the last 5 years, this is the third time this has been asked. Absence of nuclei in the tail tip. This is our microfilaria of Wuchereria bancrofti. It has a cephalic space which is square shaped, a distinct nuclei in the body, and absence of nuclei in the tail tip. Brugia malayi has a rectangular cephalic space. There is a blurred nuclear column, and there are two nuclei in the tail tip. Remember those two differences. Moving on, a young male who has returned from USA developed fever, cough and breathlessness. Chest X-ray showed presence of bilateral hilar mediastinal lymphadenopathy. Culture on SDA. So we have a fungal infection which is mainly reported from USA, presenting with a mediastinitis and hilar lymphadenopathy. So this is definitely histoplasmosis, also called as Ohio disease, also called as Darling's disease, because it is endemic in Ohio and Mississippi river valleys, and after the person who investigated it, it is known as Darling's disease. Lactophenol cotton blue mount of the colony showed the findings as shown in the image. So you can see some hyphae, you can see tiny macroconidia, and you can see the biggest clue. These are the tuberculate macroconidia of histoplasma. Very important. The morphology of the dimorphic fungi is very, very important. So we've come across three morphologies in our NEET-24 exam of the dimorphic fungi. First, we were asked about Coccidioides, then we were asked about Blastomyces, now we've come across histoplasma, right? So anytime you have a fungal infection which is presenting with mediastinitis, think of histoplasma, and of course the origin is mentioned, you are seeing tuberculate macroconidia. Also remember, this is the mold form. What about the yeast form? That has been asked as an image-based question. Yeasts are seen, you see tiny budding yeast inside macrophages. Okay, think of histoplasma. Budding yeast in macrophages. A 22-year-old farmer developed an ulcer on the feet with white powdery granules and multiple discharging sinuses. What are you going to diagnose? This is mycetoma. Granules with discharging sinuses. Microscopy of the granules shows gram-positive filamentous organisms with branching. Whenever we think of gram-positive filamentous rods showing branchings, we are going to think of one family of bacteria, that is Actinomycetes. And which Actinomycetes causes mycetoma? It is the aerobic Actinomycetes. Nocardia, the most important one, and that is what is mentioned out here. Nocardia is our answer. Yes, Staph aureus can cause a similar appearance. That condition is called as Botryomycosis. But there you're going to see gram-positive cocci. You're not going to see gram-positive filamentous rods which show branching. Mucormycosis does not present like this as sinuses, and there you would see aseptate hyphae showing obtuse angled or 90-degree angled branching. Sporothrix schenki, it would be stained not with gram stain, it would be seen with Gomory's methenamine silver, right? So pretty simple, nocardia is our answer. So here the diagnosis is actinomycetoma due to nocardia. That's our nocardia. The colonies have been stained with gram stain. We are seeing gram-positive filamentous rods showing branching. An elderly female was put on a central venous line before being taken up for surgery. On post-op day 3, she develops fever with tachycardia. The tip of the central line was sent to the microbiology lab and culture showed buff colonies. Microscopy showed gram-positive organism that reproduce by budding. So we are talking about a yeast or a yeast-like fungus because these are show budding. What is the likely causative organism? Candida, yes, that is definitely our answer. It can be easily stained by gram stain and it shows budding. Definitely not staph epidermidis because that would not show budding. It divides by binary fission. So also streptococcus divides by binary fission. Aspergillus does not divide by budding. It is a hyaline septate mold. Let me show you the images, related images. This is the colony of Candida. These are buff means off white. These are off white pasty colonies of Candida. And this is the gram stain, gram positive yeast cells, rounded yeasts, which divide by budding. Okay. And this is Aspergillus, the hyaline septate mold, which is showing this conidiophore on with, at the end of which you are seeing a swollen structure called as a vesicle, and you are seeing these finger-like projections which are known as phyllides, and you're seeing these conidiophores. Okay. Aspergillus has no yeast stage, and a very, very important picture is in the tissue. This is the Gomori's methanamine stain of a tissue section. It's actually a lung biopsy. And here what is so typical is this dichotomous branching, acute angle or dichotomous branching. Hyphae. Very, very important about Aspergillus. A group of hostel boys consumed hamburgers from a local street shop. 3 days later, some of them developed abdominal pain, vomiting, and bloody diarrhea. One of them was diagnosed with hemolytic uremic syndrome. Stool cultures were done. So, are you forming a diagnosis here? We have a history of burgers, very, very important, with bloody diarrhea. This is definitely enterohemorrhagic E. coli. And of course, HUS is mentioned out here. Stool cultures were done, and after biochemical testing and serotyping, the etiology was identified as E. coli O157H7. What does the H indicate in this and the identity of this isolate? This is so simple. The H antigen is the flagellar antigen. What about the O? That's the somatic antigen, which is part of the LPS, the endotoxin. The outermost part is the O antigen, right? So, O stands for the somatic antigen, part of the LPS. H stands for the flagellar antigen. That's the most dangerous isolate amongst the enterohemorrhagic E. coli, often associated with hemolytic uremic syndrome. I hope you also remember that special medium sorbitol McConkey agar, on which E. coli O157H7 does not ferment sorbitol and hence produces pale colored colonies on sorbitol McConkey agar. A 30-year-old male from Bihar presents with high-grade fever off and on and abdominal swelling for the last few weeks. On examination, the patient has marked pallor, massive splenomegaly. So, what are we arriving? Bihar patient with abdominal swelling, with fever, with pallor. We are arriving at a diagnosis of Kala-azar. The bite of which of the following has transmitted the most likely infection? We know the vector for Kala-azar is Phlebotomus or sandfly. Pretty simple. Okay. So, that's an image of the sandfly. Let's move on to our last question. A young female who uses contact lenses presents with severe itching, watering, and redness of the eyes for the last 2 days. So, she is presented with keratitis. So, this is a contact lens user. On questioning, she says that she is not very regular with changing her contact lens solution. Microscopy of the solution shows motile structures with spine-like pseudopodia. So, this is an amoeba which is causing keratitis in a contact lens user. And we know, of course, the answer to this is acanthamoeba. Acanthamoeba has been asked in the last 3 years twice before. Spine-like pseudopodia, an electron microscopic image has been shown. Here it is just straight away mentioned. Okay. All these options mentioned, Balamothia, Naegleria and Sapenia, these are all free-living amoebae, but the one which is associated with contact lens keratitis is definitely acanthamoeba. Okay. This is the electron microscopic image of acanthamoeba. You can see these spine-like pseudopodia on its surface. Well, that's were all the questions that were discussed, that were asked in the NEET exam. Bye-bye. Thank you.